Thank you, Mr. Chairman. Massive retracted rotator cuff tear is the main indication for the reverse prosthesis because it's a very good alternative, a very good option, because sometimes it's impossible to repair the massive retracted rotator cuff tear. But is my disclosure. But we must have a good definition of massive retracted cuff tear. And you need to check the muscle and tendon quality. And you see in a retracted and irreparable cuff tear, the reducibility is impossible, but you cannot check the reducibility before the surgery. It's very, you have no exam to appreciate the irreducibility of the cuff. The muscle is very important to check before you decide to repair the cuff tear. You need to appreciate the volume of the muscle and the muscle atrophy, and also the fatty infiltration of the muscle. If you have muscle atrophy with a big infiltration, a fatty infiltration of the rest of the muscle, it's no way to repair the tear, because it's very difficult to repair and the muscle doesn't work anymore after the repair. Delamination of the tendon is very, very important to check also, and the size of tear is very, very important to check. You see the quality of the muscle in the right picture, and I mean, it's impossible to repair that. If you have massive retracted cuff tear, what have you as option to repair? Debridement, arthroscopic or open repair with a partial repair, capsular superior repair. You can use some spacer, and you have some option with tendon transfer surgery. You have also arthrodesis option, because arthrodesis at the level of the shoulder restore some mobility. And the last option, but actually the main option, is reverse shoulder arthroplasty. I mean, you need to select the patient for the reverse arthroplasty, because you can have some difficulties to make the revision of reverse arthroplasty. And certainly, you need to select all patients with a pseudo-paralytic shoulder on very poor pain score. For the reverse shoulder arthroplasty, what the best option for the approach? The Mackenzie Antero superior approach is a good option because you have a very good glenoid overview, and but you damage the deltoid, and you can have a good option for prepare the humeral resection, and it's more difficult to have extensive exposure of the arm of the humerus on the glenoid side. Deltopectoral approach is another option, but you can have a nerve damage because you need to dislocate the shoulder. With the Mackenzie approach, you don't need dislocate the shoulder to implant the prosthesis. With the deltopectoral approach, probably you can have more instability after, and you need to repair subscap and pec major every time to secure the stability of the shoulder. Antero, the glenoid exposure is the best with the antero-superior approach because you have the glenoid side in front of you, and you can manage very well the implantation of the glenosphere and metaglen and glenosphere. And you don't need a glenohumeral dislocation. You just move the humerus down, and it's less aggressive for the axillary nerve. You see the trail of the axillary nerve. You see the prosthesis, and you move the nerve very, very close to the subscapularis muscle. The humeral resection with the Mackenzie approach is definitively easy, especially if you don't have any tendon. During this approach, you need to check the posterior part of tendon, the teres minor, because it's very important to check it to be sure to have external rotation after the surgery. Humeral resection is done in a neutral position without dislocation, and you can respect the anatomical retroversion with the cut of the humeral head and with the implantation of the stem after, or stemless after that. The glenoid bone stock is a big deal during the procedure because you need to respect the bone stock as well, especially in the glenoid side. During the reverse prosthesis, you need to protect as well the rest of the subscapularis, because subscapularis are 2/3, and the inferior third is without tendon, and the muscle goes directly to the humeral insertion, and very frequently is respect by the tear, and you need to conserve it to have more stability for the reverse and good internal rotation, the best internal rotation you can expect. You can have a different angle for the humeral side. The capsular release is very important to have the most mobility after the procedure. You see the true U retractor to have a good exposure of the glenoid side. The best position of the glenosphere is down as possible to have the less damage of the inferior pillar and less notching as possible. The diameter of the glenosphere is regarding the works from Ludwig Zebauer, the bigger as possible, and you make more stability, you have humeral lateralization, and you have the most mobility you can expect. The arm lengthening is important, but you don't lengthen too much because you can have some fracture of acromion and atrophy of deltoid after that. So long-term outcomes seems better every time. And the last publication from Laurent Nové-Josserand is very interesting because you can expect more and more with the reverse prosthesis. But there is some failure, and failure can be devastating, especially with the infection, with the glenoid notching, with the fracture, and neurological complication and dislocation. The clinical assessment of the external rotation is very important because L'Episcopo described for the burst palsy the latissimus dorsi transfer. In first, he describes a teres major transfer, and after he modified. And Merle d'Aubigné modifies this technique, and you can use it combined with reverse prosthesis. It was described by Pascal Boileau, and it's very interesting because you move the two tendons, latissimus dorsi and teres major, to restore external rotation. You fix it in the same place on humeral shaft, and it's a initial draw from Merle d'Aubigné, and you can have a good external rotation after the combination of reverse and latissimus dorsi transfer. Thank you so much.